Dr. Alicia Kowalchuk. I'm Medical Director for the Harris County Hospital District's Insight program, which is our screening, brief intervention, and referral to treatment program within the hospital district. Our goal is to serve the healthcare needs of the roughly 1.3 million uninsured folks in our county. The original grant was written by a colleague of mine, Dr. Katie McQueen, and also by physician assistant professor here at Baylor, Vicki Waters, and they wrote a white paper around SBIRT services and a lack of SBIRT services here in Harris County, and then subsequently got the funding for SAMHSA, applied for the grant through SAMHSA, and they had both experience working at Bentock General Hospital, and so that was a logical, obvious choice to start a level 1 trauma center, and so that's where we began. The biggest challenge is the obvious one. These are busy places. There's a lot of competing priorities, and while all staff seem to acknowledge that substance use issues play a big role in what they do on a day-to-day basis, the patients that they see and the problems that they come with are often very linked to substance use disorders, if not directly the reason that they're in the emergency centers. Actually getting them to take time out to do, yet one more thing, so to speak, can be challenging. So we initially started with a 10-item screen and found that was much too lengthy for, again, frontline staff to implement. We used the audit at that time and also wanted them to ask a brief drug screening question and ask about tobacco. So actually it ended up being 12 questions total when you total up tobacco, alcohol, and drugs. Thankfully, over the course of the grant, we kind of pared back. We first pared back to the briefer audit, the audit C. And then with the publication of the NIAAA single question drug screen, which has been validated to be as sensitive and specific as the cage, for example, we were able to transition to a single question for alcohol use in addition to our single question for drug use and tobacco. So that really helped us in continuing our implementation. At LBJ, we got to start fresh with that, and it wasn't as big of a transition as it had been at Bentock, where we kind of started big and then pared down. So really having just 3 questions, and the way we framed it was you were already asking these questions, and most folks, when we queried, were saying, do you drink, do you smoke, do you use drugs? And so we were able to come in and say, you're not going to have to ask any more than 3 questions. The questions may be a bit longer, but they're going to give you a lot better information. They're validated, etc. And so we currently having them ask, do you smoke? When was the last time you had 4 or more drinks in one day? And do you use marijuana, cocaine, or other drugs? We are now currently working on transitioning to the newly validated single question drug screen. Prior to this month, actually, July 2010, we didn't have a single question well-validated drug screen. We chose marijuana and cocaine in our site because those are our most common drugs of abuse. But that would made the training seem a lot more natural. We have 3 questions. You're generally already asking 3 questions, but you're going to ask something that's been validated, and really stressed with our staff that they're already doing and wanting to do other medical interventions, screenings, studies, tests that have the best evidence, and really tying into this is just another evidence-based thing that we do. Just like taking a blood pressure, doing your pain scores, this is just standard of care. And we sort of anticipated that some resistance to doing a screening test and feeling like there may not be a big difference in outcomes based on the screening results. So what I mean by that is kind of the old maxim, you don't look for something that you can't treat or you're not going to treat. And so there were two aspects to that staff expressed concerns about. One is substance use disorder treatment really effective? And so, we did a lot of upfront education around what are substance use disorders, that there is effective treatment, that treatment is available to our patients, particularly in our setting, which is very underserved, that there is state-funded treatment option available. And then the other piece is that, are we going to be able to link to that treatment? So they were both very related. So their fear was we're going to identify someone with a substance use disorder, but we have no way of either getting into treatment or that treatment isn't effective. And so we also had to provide some basic education around substance use disorders, that there is effective treatment, and also a lot of education around SBIRT itself. What I mean by that is that, SBIRT is principally geared to patients at the misuse level, not at the abuse or dependence level where they need that referral to treatment. It's geared at that public health, get people before they've progressed into abuse or dependency, where a brief intervention has shown to be effective. And so a big challenge off the bat was that we would get referrals from folks that were obviously substance use disordered, but maybe not the routine screening that we were hoping for. So, the patient, the frequent flyer that was there 4 or 5 times for, cocaine-related chest pain in the past 6 months, they would refer, but we didn't always see that screening was happening routinely with everyone. And so we did a work around incentives, pizza parties and things like that for, the clerks that were able to enter the SBIRT, referrals for our specialists to come and intervene with patients, et cetera. And that helped kind of raise the level of awareness. And then just lots of education around what is SBIRT, what's the primary goal of SBIRT, that yes, we want to take care of your patients that have abuse and dependency and help link them into treatment, but our goal is also, and we've been shown to be most effective for folks that are really at that misuse level. So the education really had to be very comprehensive around substance use disorders and the full spectrum, not just abuse and dependency. Right. Some other obstacles was simply just space issues, so we felt it very important that our specialists be co-located in the emergency centers in particular, so that they were seen. Folks could see them doing their work. We could also see them, charting and documenting, and we weren't perceived as just this department somewhere out there or this group of people somewhere out there that weren't connected to them or that were hard to get a hold of. And so negotiating for space was a big issue because as most ERs, that space is of a premium in most hospitals and particularly in emergency departments. And so that was a challenge, and our staff had to get adapted. Well, we're doing a renovation here, or we're adding another something over here, an ultrasound machine or whatever, so we're moving you again. And, our staff had to be really adaptable and not too territorial, so that was very helpful. And to understand that, no one really had a sacred space in the ERs, in the emergency departments. Everyone kind of has to be mobile and flexible and things like that. So it was also important for us to have staff that were adaptable and saw their role in that way. I think the biggest obstacle was cost and how we were going to help the district in terms of cost. Since our grant, there have been SBIRT codes approved for both Medicaid, Medicare, and private insurers, so it is a reimbursable event now, so to speak. You can bill for it. Unfortunately, within our hospital district system, so few of our patients actually have any insurance besides the county-funded insurance that that really wasn't a big selling point for them, even though that was kind of coming online just as our grant was ending. The other thing that we did a cost study analysis. We looked at a little over 800 of our patients. These were consecutive. The second year we were providing SBIRT services at the hospital district. This was both inpatient and outpatient. And we assessed their charges to the district the year before, that initial contact with our provider, and then the year after. And we showed that we saved the hospital about $4 million over those 800 and some patients. And that was pretty powerful. That really got our foot in the door. And what we showed was that we decreased hospitalization rates, length of hospital stays. When folks did show up into the hospital, we decreased emergency center visits, and we actually increased community health center visits. So we did exactly what the model is supposed to do, which is, really move people from, using the EC or inpatient stays because of their substance use disorders, most likely, and really stabilizing them and getting them into the community, getting them linked to services and more appropriate long-term care than this acute episodic care. And so that was pretty powerful. In terms of training our staff, the biggest part of our model that was rather unique from the other pilot programs around the country is the extent of our motivational interviewing training for our providers. And so they received 3 full days of intensive motivational interviewing training for our staff that provided brief intervention. For our brief intensive intervention or brief therapy staff, they received an additional day. We also did observed structured clinical exams with our staff after they had at least 2 days of training, full days of training, and a month or 2 of experience working with patients. And they got direct feedback after those interactions. And then the most unique part was that we still to this day provide ongoing coaching around motivational interviewing. So they tape their patient sessions and upload them to a website where our motivational interviewing coaches provide direct feedback in addition to some one-on-one coaching time either by phone or in person. But the move to the uploaded model, the digital recording, really helped us continue those services post-grant, because it obviously decreased our costs of live in-person coaching, where we had to pay for coaches to come and sit for an hour, 2 hours, perhaps, waiting for there to be an intervention and then, proceeding with the intervention, etc. Now they can listen to several on the web, provide the feedback, and it also helped our specialists be able to work that in easier to their clinical time.